Okay, well, we'll wait a minute or so, so a few more people are likely to log in, and it's just barely 11, so. All right, to be conscious of everybody's, time, we'll get started here. I'm Jonathan Haynes. I'm going to be moderating the session today. A couple of housekeeping notes just for everybody who's on. This webinar is being recorded and will be available for viewing at the UH Research and Education Institute website. If you're Please mute your microphones so that we can have a clear presentation, clear and easy presentation. Um, if you want to ask questions, there's a Q&A section over there that you can put questions in so that we can talk about those once the presentation is over. And for those who are in the meet and greet, which is after this, remain on this Zoom, and we'll do the Q&A. So it's actually my pleasure to introduce Ann McKee. Dr. McKee is the William Fairfield Warren Distinguished Professor of Neurology and Pathology. She's board certified neurologist and neuropathologist. She's director of the Boston University Alzheimer's Disease Research Center, the director of the Boston University CTE Center, and the director of neuropathology service at the VA in Boston. She has established that repetitive head impacts, including concussive and non-concussive impacts, such as those experienced by contact sports athletes, military service members, or victims of domestic violence, cause a progressive tauopathy, CTE. She defined the key neuropathological features for the diagnosis and staging of chronic traumatic encephalopathy, CTE. Her research, including the creation of the Unite Brain Bank, the largest brain bank focused on long-term effects of brain trauma, is the primary reason that CTE is now considered a major public health concern worldwide. She's a member of the National Academy of Medicine, has received numerous awards for her work. And with that, I'm going to turn it over to Dr. McKee, who will give us her presentation.
Okay, thank you. Thank you for that kind introduction. It's a pleasure to be here. I am going to talk today about my work at Boston University and the VA in Boston, and I'm going to talk about what we've learned from the brains of contact sport athletes over the last now 17 years. So just to start off, I have no disclosures. So what I'm going to talk about today are repetitive head impacts. And importantly, that includes concussion, but much more often the non-concussive impact. So a head impact is a mild traumatic brain injury induced by mechanical forces to the head, face, neck, or body that leads to this acceleration, deceleration, and rotational forces on the brain. And you'll notice this happens underneath the skull, and that's why helmets, which protect the skull, are not going to be the solution to this injury. So these repetitive head impacts can cause acute structural injury to the brain. If they cause symptoms, that's called a concussion. If it doesn't cause symptoms, it's called a non-concussive impact. And there are many more non-concussive impacts than concussive impacts in the play of most sports. And importantly, it doesn't mean that the non-concussive impacts are lesser. They're often of equal or greater magnitude than those that cause symptoms. What I'm going to talk about today is chronic or prolonged exposure to these head impacts that occurs during the play of contact sports like ice hockey, football, rugby, soccer. I'm talking about exposure over years, sometimes decades. And that is at this point in the science, the only known cause of a neurodegenerative disease called CTE, or chronic traumatic encephalopathy. So acute concussion, RHI, acute injury causes axonal injury, inflammation, it damages the blood vessels, it causes loss of white matter, neurons and synapses, and it causes a change in astrocytes. But this is an acute injury, and we think it resolves with time and rest, but the trajectory is not entirely known. What I'm talking about is prolonged exposure, chronic exposure to these head impacts, and that gives rise to neurodegeneration. The primary neurodegeneration is CTE, which I'm going to focus on, but other diseases can occur as well, other post-traumatic neurodegenerations like Lewy body disease, amyloid deposition, TDP-43 proteinopathy, hippocampal sclerosis, and ALS. And all of those can occur in combination. So CTE is a tau-based neurodegeneration. It can currently only be diagnosed by postmortem exam, and it can be suspected during life. One of the greatest goals of all researchers in this field is to develop a way to diagnose this disease during life, and the most promising methods are fluid biomarkers and imaging, PET scans, to detect tau. The clinical syndrome associated with CTE pathology is called TES, or traumatic encephalopathy syndrome. I'm not going to talk a lot about that today. This is a disease that's been around for nearly 100 years, first described by a pathologist who described the clinical symptoms in boxers who he said stayed in the ring too long. Then there were case reports throughout the 1900s. But it wasn't until the 2000s that we really started understanding that this is a disease that could affect current sport athletes, including football players and boxers. My first case was in 2003. It was a boxer who came into the Alzheimer's Center with a diagnosis of Alzheimer's disease. Everyone thought that's what he was going to have. And at post, I saw the most extraordinary tauopathy I'd ever seen, and that's what piqued my interest. It was really this extraordinarily florid disease that had this very peculiar pattern engulfing blood vessels and occurring in areas of the brain that are not usually affected. And that began my scientific interest in this disease. And then, as luck or providence would have it, I was asked to look at the brains of former NFL players in 2008, and I was very eager to do this, given what I had seen in the brain of a boxer. These were my first two NFL players, Tom McKee and John Grinsley. They were only 45 when they died. Both had died of accidents. Both their wives had thought they had some difficult to describe problems. Tom became addicted to painkillers, which was quite unlike him, had trouble with depression and planning an organization. John had trouble multitasking, was beginning to become forgetful, and both died of accidental injuries. And then when I looked at their brains, I was really stunned to see that both of these 45-year-olds had a very pronounced neurodegeneration, a tauopathy. There was no beta amyloid, and it looked for all the world just like what I'd seen in the boxer. It wasn't quite as severe, but then again, they died some 30 years younger than the boxer, so that was to be expected. That's what started my whole interest in this. That's where we started the brain bank. We have over 1,700 brain donors at this point. We've had many, many famous visitors to the brain bank. And the brain bank really has been the basis for a lot of our scientific research to date on CTE. Over the last 10 years, there were consensus panels convened by NINDS to define the pathognomonic lesion of CTE. That was defined as a pathognomonic lesion around a blood vessel. It's a perivascular lesion, and it preferentially occurs at the crevices of the brain. So here's just a further demonstration of that. The tau in nerve cells surrounding small blood vessels in the brain, a unique feature of CTE not seen in any other tauopathy. And then this predilection for the depths of the sulci or the crevices of the brain, and very pronounced involvement of the frontal cortex. Again, key features of CTE. We also described a staging scheme where the earliest cases are just focal abnormalities in the frontal cortex in mild CTE, which affects younger players. And then more severe CTE starts to progress into widespread regions of the brain. Notably, it starts to involve hippocampus, entorhinal, and amygdala in stage 3, and then becomes a widespread tauopathy in stage 4. And these later stages, more severe CTE, stage 3 and 4, are associated with cognitive decline and dementia. And all of these stages correlate with age at death. It's a progressive disease that gets more severe with aging, even though the people have retired from their sports and are not getting more hits to the head. And it also correlates with the years of play, which we use as a proxy for the cumulative number of hits to the head they've been exposed to. This is just another demonstration of low and high or mild and severe CTE, starting out as a focal injury, primarily in the frontal cortex, but it can affect frontal and temporal, parietal and temporal, and then a more widespread disease later on. We think the reason the tau is deposited in those regions reflects the physics of the injury. So with that acceleration, deceleration, rotational force, the areas of the brain that are deformed the most, that are stretched the most, so that the elements of the brain like the axons and the blood vessels are injured, are actually at the crevices of the brain. There's greater torsion at the crevices of the brain and around blood vessels. So the physics of the injury explain this very particular distribution in the brain. And that's been also shown with computational and finite element models by multiple teams of investigators throughout the world. We also know in CTE, as of 2019, that the tau in CTE is distinct from all other tauopathies. It has a hydrophobic element at the inside its filament, and it's distinct from Alzheimer's disease, PSP, CBD, any tauopathy you can name. CTE has a distinct cryo-EM structure. The filament in CTE is unique. As for symptoms, I'm going to briefly mention those today, but when we looked at all of the pathologically verified cases of CTE back in 2014, the most common symptoms were a variety of behavioral, mood, and cognitive changes. And of those, the behavioral and mood changes tend to occur earliest. They can be a variety of things like violence and explosivity, short fuse, poor impulse control, depression, hopelessness. But from my standpoint, one of the more disabling symptoms is loss of control. The person has a sense that something's not right, something's going on in their brain, and they can't seem to control it. They can't control their thoughts. They can't control their behaviors. And then later on, when the disease is worse, we see cognitive impairment and dementia, executive dysfunction, memory loss, and those correlate very well with the amount of tau in the brain. We have less of a direct relationship between the behavioral mood symptoms and the amount of tau in the brain. There's some suggestion that behavioral regulation, the ability to regulate your moods, your behavior, is related to tau in the frontal cortex. But we're still searching for why you get this variety of behavioral and mood changes early in disease. And we think it may be related to the other structural brain injuries that occur with these hits, like white matter loss, like vascular injury, and the tremendous inflammation that occurs. So this was a paper we had in 2017. It got a lot of attention all over the world, because it had some very scary numbers. We looked at all the football players that had come into the bank. At that point, there were 202, and we found that when we looked when we looked at all the NFL players, which were 111, we found that 99% had CTE. And of the college players, 91% had CTE. Now, there's tremendous selection bias in a brain bank. We're only getting cases that families thought was, there was something wrong with the individual. They wanted to have it looked into. So it's a skewed population. It doesn't represent the general population. But even in this skewed population, these numbers are extremely high. And even amongst high school football players, we're seeing about 20% with CTE. And that becomes more impressive when you look at how infrequent CTE is in the community and community-based brain banks. This has been done all over the world. And to find CTE in a community-based study is quite rare, 0 to 2%. I'm going to show you a quick case, Aaron Hernandez. I show this case because a lot of people are familiar with him due to his Netflix series and other media presentations. But here's a brain of Aaron Hernandez, who died at the age of 27. This is the brain coming into the lab, and me and my colleague Victor Alvarez are doing the dissection. We're looking for gross abnormalities. The brain itself, when we looked at it as a whole, looked entirely fine. I didn't think there was anything wrong when we looked at it on the external view. But when we started to dissect through the center of the brain, we could see immediately that there was ventricular dilatation. So that's not normal. And we also saw there was this tremendous atrophy of the fornix, thinness and degeneration of the fornix, which is not normal. And there were holes in the septum pellucidum, which is quite unusual. And that's usually seen in individuals with severe CTE or individuals who've had quite a bit of trauma to their head. And we did see that in Aaron Hernandez. So immediately we're thinking we're going to see something under the microscope. And yes, we did. We saw the classic changes of CTE, the tau in nerve cells around blood vessels. They were quite numerous. And if you look at this, these are coronal sections through the frontal aspect of the brain. And this is looking at it with the naked eye. There's no magnification. This is tremendous tau involvement of the frontal lobe in Aaron Hernandez. And there's beginning involvement in the medial temporal lobe. So he was diagnosed with CTE stage 3. We know now that CTE can occur in women. It's recorded much less frequently, often in the context of domestic violence. But this was one of the first contact sport players described with CTE. This was a woman who played Australian rules football in Australia, also was in the military and participated in mixed martial arts. And when she died at the age of in her late 20s, she had early stage mild CTE or CTE stage 1 with the classic changes. One of the most important aspects of our research was establishing that there is a clear dose relationship between length of playing career and odds of developing CTE. And this was a study done in 2019 by Jesse Mez, Dan Danchavar, and Patrick Kernan. And they found that they use very sophisticated simulation and inverse probability weighting to account for the degree of selection bias in the brain bank. And they found that no matter how high the selection bias, this was a very constant relationship, that the risk of CTE increased by 30% per year, or for every 2.6 years of football, the odds of developing CTE doubled. So this was, I think, very important paper. And then it was followed a few years ago by another paper with Dan Danchavar showing it's not just the cumulative number of hits, it's not just the number of playing years, but it's also the strength of the hits. And there are certain positions that get harder hits than others. And in this paper, defensive backs like running backs and wide receivers were found to have the greatest magnitude of hits and an increased likelihood to develop CTE. We know CTE occurs in other sports. It's been well described in rugby. We also found there was a dose duration with playing years in rugby. For every additional year of play, there's a 14% higher risk of developing CTE. And we've shown the same in ice hockey, where the odds of having CTE increase by about 34% for each year of ice hockey. Ice hockey, like football, is more commonly reported in players who play at a higher level because in general, they play longer. So professional players in our series had about 96% of them had CTE, about 46% of college, junior league, and semi-pro had CTE. But again, there's this youth and high school player who not frequently, but we find early cases of CTE. And this is just a violin plot showing the greater years of play are associated with more likelihood for developing CTE. So I wanted to end on this study, which came out 2 years ago, but this is an important study that was very important to me, and I think is important in light of recent events in New York. This was a paper I wanted to do since the 2008, because my third case of CTE was in a high school player. He played high school football and rugby, and he died at the age of 18. It was a case that I never forgot. Eric Pelly, imaged here, this young player, and he has the changes of CTE in his brain, which to me was really shocking. I was really having a hard time wrapping my head around that a teenager could have early signs of neurodegeneration in their brain. So we looked at, what we did is we put together all the cases, all the contact sport players who had come into the bank and had died before the age of 30. So they ranged in age from 17 to 29. And of those 152 players, contact sport athletes, we found that CTE was present in 63% of them, or a little over 40%. So not infrequently, we found that these teenage and 20-some-year-olds were developing CTE. And most of the time, these players played amateur sports. They weren't in the pro leagues. Most of them played American football, ice hockey, soccer, rugby, and wrestling. I'm talking about amateur wrestling, and even high school wrestling can be associated with CTE. There was one woman in this study who played college soccer who also had CTE. And I'm just going to use some graphics that were developed by the New York Times to show, to make these points. So there were 152 contact sport athletes, 63 developed CTE. Of those 63 with CTE, most were football players. They started playing football young as 6, and they died in their teens and 20s with CTE. Nearly all were diagnosed with stage 1 or 2. There were 3 that were diagnosed with stage 3. One was Aaron Hernandez, another was a college football player, and another was an amateur rugby player. I want to share this video with you just to give you a glimpse into the workings of the mind in these individuals that have CTE. There is a recognition that things aren't right. And I think in this case, this is a high school player. This is Wyatt Bramwell. This is a video he took right before he took his own life, but it does describe what they're going through.
So what this is me explaining what's wrong with me. I've been depressed for a long time, and I've attempted suicide twice, and this is gonna be the third time. It is my way out of my head. My head is pretty messed up and damaged. My thoughts never stop racing. I always have racing thoughts, and I can never think straight. But I've been depressed for a long time. Ever since probably freshman year of high school, I've had issues. And I covered it up with activities, going to booths, playing football, hanging out with friends, playing PS4. And over the years, it got worse. Sophomore year was pretty bad at the end. And then junior year was easy. Senior year was the easiest. I'll explain that why as well. But the voices and demons in my head just started to take over everything I wanted to do. Hanging out with friends, enjoying time with family, riding my bike, and just daily activities started to become not so interesting for me. I'm really sorry for this. I really am. But I just want you to know that I can rest easy now. That's what's important about this. And I want you all to be happy. And I want you all to come together and bond over this. You know, don't feel guilty, like I said, don't feel bad. You can be sad. I know you'll be sad. But at the end of the day, be like, you know, Wyatt's in a better place. This is what he wanted. I feel good for Wyatt. I feel happy for him. He suffered and he's not suffering anymore. And that's what's important. And I want all of you to come together. You know, I'm not saying you have to get in a circle and sing Kumbaya and give a big group hug. If you want to, that's completely fine. I don't care. But I want you all to come together and
I'm sorry I'm cutting it off, but I just wanted you to get the gist of it, not the entire thing. And his brain did come to us, and he did have CTE stage 2. This is what the brains of these young athletes looks like. It's usual focal abnormalities in the frontal lobes, sometimes in the temporal lobes and parietal. Most of them were diagnosed with low or mild stage CTE. But we did see macroscopic brain changes that were significantly associated with CTE, and those included cavum septum pellucidum, dilatation of the frontal horns, meaning brain atrophy, and also dilatation of the third ventricle. So there's been atrophy not only of the cortex, but also of the thalamus. And that's what those changes look like. These are the young people's brains with cavum, dilatation of the ventricles, and even dilatation of the third ventricle. We saw in these individuals classic CTE lesions. They were entirely neuronal. They were around blood vessels. They tended to be isolated, very discrete foci, mostly in the frontal lobe. And they also correlated with some microscopic changes other than just tau. So there was a trend, it wasn't significant, but there was a trend for more white matter loss in these individuals. And also there were more frontal perivascular macrophages. And I'm going to show you what that is in a second. But that indicates that there's been vascular injury. The vessels become injured, they become leaky, and the blood tends to leak out of the vessel and be engulfed by macrophages. And not only were these perivascular macrophages seen significantly more in CTE, we also found that they directly correlated with years of play. So this is just showing you what these macrophages look like under the microscope, these dense collection of heme containing macrophages around blood vessels. There's also tremendous inflammation in these brains and white matter loss. So just a couple of other statistics. The brain donors in this group were those with CTE were on average about 4 years older than those who didn't develop CTE. So the mean was about 25 for those who had CTE, 21 for those who did not. And football players with CTE played on average about 3 years longer than those without CTE. And notice it's about 11.6 years in the football players with CTE. And we've noticed in our work that there's a flexion point of about 11 years where, you know, before 11 years, you're not as associated with risk of CTE, but there seems to be around 11 years of play in football, there's a dramatic rise in your risk. So if you look at that same group and you look at just the players who only played as high as high school football, there were 45 in that group. And of those, 14, almost 30% had CTE, so almost 1 in 3. And I think that's a pretty alarming finding, especially in view of the events in New York, where the tragedy took place and a shooter took the lives of 4 people. But there is a possibility, and it's no excuse for any kind of behavior, but he was concerned he had CTE. And he's not without cause. There is a possibility he had CTE. It's also likely he had something else altogether, unrelated to football and unrelated. But I would like the public to be more aware that there are clear risks to this amateur level of play, the level of play that that athletes participate in association with educational institutions like high school and colleges. There is a risk, and in my opinion, it's too high a risk. It's a risk that needs to be mitigated and needs to be addressed, and we are not addressing it. So the clinical symptoms in this group of 150, we couldn't tell the difference between those who had CTE and those who didn't. The symptoms included poor impulse control, explosivity, anxiety, depression, and suicidality. There were also cognitive symptoms of episodic memory loss, loss of executive function, and attention problems. But they were shared by both those with CTE and those without. And we think that just the hits to the head themselves, the inflammation, the white matter loss, the damage to the blood vessels, they probably cause symptoms too. So that may be why we can't tell them apart, those who have developed tau from those who haven't. But the other thing is we're doing retrospective review of symptoms, right? We're not looking at the person. He's not coming into clinic. We're not doing neuropsych testing. We're not being able to do MRIs and brain scans and things that would really help us with diagnosis on those. This is just based on interviews with the families. So it's probably that our tech method lacks granularity. It lacks sufficient detail to be able to discern those with CTE and those without. So I just want to end this with what I think really needs to be done. And I do think it's high time, in fact, it's way past time, to take this much more seriously. This is not a disease that affects only professional NFL and other pro athletes. This affects high school and college level players. And the only way we're going to prevent it is addressing the number of head impacts that occur in these sports. We have to reduce heading in soccer. In football, we can do things like reduce the number of games, shorten the game length. We can limit the amount of head contact in practice. We could eliminate head hits in practice altogether. It could be no contact practice. We could change the age at which athletes are allowed full contact. If you just raise the age for full contact, we immediately reduce the number of years of play. But then the other thing which we're not addressing is no one is actively assessing players. No one's trying to monitor the number of hits to the head that the players are experiencing. There's no attempt to keep track of the hits, and we have the technology, but no one wants to do it because the data is well, they don't want the data, and no one is evaluating athletes in a precise way at the beginning and end of the season to detect white matter changes, to detect inflammation, to detect changes in neuropsychs. So we can suspect CTE during life. We don't have an ability to absolutely diagnose it, but we can suspect it. And our suspicions can be aided by neuropsych testing, blood-based biomarkers, and structural imaging scans. There's a FLAIR MRI finding that we've just reported recently in Alzheimer's and dementia that we're seeing in CTE, individuals who were known to have CTE, and there's this punctate abnormality of the white matter, which is quite unlike white matter changes that are associated with aging and Alzheimer's disease. And we're doing more studies to see if this is specific for the development of CTE. And then we're doing blood-based biomarkers as well as spinal fluid, looking for pretty conventional markers, but hoping to find some that can detect these changes earlier in life. We have a bank CTE, that's the website for it, www.bankcte.org. And anyone who's a former contact sport player can assess the online survey and fill out the signs and symptoms, get a single blood draw from a Quest laboratory, send it to us, and pledge to donate their brain upon death. So I just want to thank you, and I want to thank all the athletes that contributed to this study. I just have a really hard time understanding why we haven't done more to prevent an entirely preventable neurodegeneration. And I want to thank my funding sources and my team. It takes a huge group of people to do this work, and I want to thank you.
Well, thank you, Anne, for that very interesting and powerful presentation. And at this point, I think we're open for a few questions. There's one question in the Q&A already. I don't know, Anne, if you can read that, or should I read it for you?
I can read it.
Okay.
So the question is, how common is CTE pathology found in donated brains without the presence of other neurodegenerations like Alzheimer's, Lewy body, other tauopathies? And I'll tell you that it is directly related to the age of at death. So comorbidities are increasingly common with age at death, but we see about 60% as a pure tauopathy, all the cases when they're young until about age 40 or so, 40 to 50. Then we may start sneaking in some beta amyloid deposition, some TDP-43, but most of the cases are pure CTE, but with age, they develop multiple heterogeneous comorbidities, the most common, A beta and AD, but TDP-43 exceptionally common in later stages with hippocampal sclerosis and Lewy body disease. So all of those are often seen in combination in late stages.
So, and I guess while others are typing, I will, I have a question. I have a few questions, but I'll just ask one. Thank you for a great presentation. And you kind of touched upon this, that we need to do more in terms of public health awareness and getting the message out there, the risk associated. And so two things. First is, so the data you are showing, is it mostly from the US? On how much do we know from other parts of the world? And are the brain bank, can people from outside access as well? And second is, I think, what do you think are the most salient points? What are the salient steps we should take to get this message out to the schools and the communities and the families? What do you think is needed? A multidimensional, right, from social media to getting schools on board. So any thoughts on that? Because messaging is so important throughout this presentation. That's what I realized. I had no idea.
Yeah. So your first question was international sports. Is this affecting international sports players? And that is absolutely. Australia and New Zealand have brain banks devoted to CTE. They've been, we've been, we collaborate with them. So we certainly have seen it in those countries. The work in rugby players that I just showed you was done in collaboration with Willie Stewart at the University of Glasgow in the UK, and we also have soccer, of course, in England and Brazil. It's the most popular sport worldwide, and there's been a lot of reporting of neurodegeneration in soccer, not in living players or players that didn't have autopsies, but we suspect that neurodegeneration will be CTE. Your second question is a very difficult question, and it's very frustrating for us to know. I'm a scientist. I'm in the trenches doing this work. We really need an advocacy group. We do work with Concussion Legacy Foundation. I have gone to Congress on many occasions. But I do think it's going to have to be congressional. It's going to have to be from the government, where they really start cracking down. They take it seriously. As you know, there's a huge financial component to CTE because the professional leagues, FIFA, World Rugby, the NFL, the NHL are very reluctant to even address that this could be possibly a problem for them. They have lots of resources to throw up roadblocks, and they've been successful with that. So it's going to take, I think, an act of Congress to really get through. And I don't know how to do it otherwise. I really, if this were a problem like seatbelts or a question of infant crib slats, or, all of the things that we do to protect safety for our children, this would have been changed a long time ago. But because this is a popular sport, because this is a major industry, the sports industry, and also because this is so popular, it's a culture, it's a religion, these sports, its identity, its national identity. There's been a reluctance to take any of this work really seriously.
There are a couple more questions in the chat and the
Okay.
Q&A.
Yeah. So should psychiatrists be screening for contact sport history and CTE? If CTE is suspected, what should be the next steps? I think the APA is still working out its recommendations. So I absolutely think that any person who comes in with these very nondescript symptoms, which I know can be a part of adolescence and many other disorders, mental health disorders, very common symptoms, nothing at all specific about them, but it would be easy to get a contact sport history, because that is absolutely critical to the question of whether or not this could be brain injury. And so, just taking a complete sports history, hits to the head from other activities like falls, poorly controlled epilepsy, maybe interpersonal violence, but that is a necessity for CTE. So that would be a first step. What can you do to treat it? Well, it's symptomatic at this point, so I'm not going to have any perfect solutions, but I will say that, just the care of a committed health professional can really help. The fact that even the possibility of brain injury, that it's not really their will or part of their personality or part of their intrinsic makeup that's causing these symptoms, giving it a label is often very, very helpful to the family as well as the person. And then symptomatic relief has been shown to be helpful. But I can't underemphasize the importance of care and just comprehensive listening and not denying or dismissing these symptoms.
There's one other question in the Q&A.
So I have one. Thank you for your presentation. Is there anything that can help CTE patients improve the quality of life? I'm a licensed music therapist. I'm curious if holistic modalities would have any effect in helping patients, and I manage CTE. And I think absolutely things like music therapy are tremendously comforting. There's lots of things like structured activities, just a very, very routine, lots of routine, physical fitness, maintaining all those healthy lifestyles, important for brain health, important for people that are suffering from CTE. So, the Mediterranean diet, keeping your blood pressure in check, your blood sugar in check, maintaining, low lipid profile. So maintaining cardiovascular health, very helpful, even symptomatically, but physical fitness helps almost any neurodegenerative disease. We see it help in CTE as well. But, there's all sorts of other things, music therapy, dance therapy, and, you'll see on the, I don't have much experience with it, but there's other things that have been proposed, and there are some, infrared light treatments that have anecdotally been known to help. I would think outside the box. This is not, this is probably something that can be tremendously aided by something that isn't a pill as we now know them. Okay, and then I have one more question. Do you have time for that?
Maybe one last question.
Okay. Well, I'm going to pick, are there certain contact sports that have less associated head trauma, that have lower rates of CTE compared to rugby, football, soccer, etc.? Well, you know, it's very difficult to do this study, but there's generally lower rates of head trauma in things like lacrosse. I mean, basketball. We've never seen any CTE in any of those sports. We don't have a lot of experience with them. There's probably less in baseball unless you're a catcher and you get a lot of hits to the head. But you know, if you just look at the sport, you can be pretty clear about the risk. It's all about the hits to the head. If there's no hits in the head, or if the hits are rare or as a completely a matter of chance, then it's going to be low risk. It's completely dependent on the number of hits to the head.
I think at this point I know there are more questions, but we don't have time to do any more of those. I want to thank everybody for you know, for logging in and listening to this very, very interesting and very powerful talk. And at this point, I think we restrict it down to a small group of individuals. So thank you everybody, for all the attendees for logging in, and have a good day.